another story, something to get off my chest.
Hello and welcome to another Pyper pod. Today we're going to continue with pathophysiology and we're going to look at disorders associated with the nervous system. Now, anyone who's heard presentations from me in the past knows that I particularly love talking about spinal trauma or traumatic brain injuries, but today we're going to take a slightly different approach and we're going to look at disorders that you may not have looked at too deeply in the past, and we're going to have more of just an overview of the different types of disorders that can affect the actual nervous system itself. So before we kick into it, we'll just have a bit of the overview of the entire nervous system. So the nervous system is broken up into the central and the peripheral nervous system. Within the central we have the brain and the spinal cords. The peripheral nervous system is made up of your autonomic ganglia and your peripheral nerves themselves. Now we're not going to go into a huge amount of detail here, so if you feel that you need a review on the nervous system itself, both peripheral and central, you can go back to the lessons I did on anatomy physiology before coming to this one, because it may make just a little bit more sense. But if we start right at the top of the central nervous system, we'll have a look at the brain. So it's broken up into three main areas. So you've got your cerebrum, your brainstem, and then your cerebellum as well. Now your brainstem is broken up further into three main sections. There's a few more hidden in there, but your midbrain, your pons, and your medulla oblongata make up your brainstem. Now when we look at a cross-section of the brain, what actually makes up the brain, we have a mixture of grey matter and white matter. So grey matter is the complex cortex of neurons, and they're what's known as mostly supporting cells. So this is where most of the decisions, most of the analysis, and most of the brain work actually happens, is within the grey matter. So it's around the outer cortex, and then there's deep parts within the brain that is also made up of grey matter. The main ones is your basal ganglion, your thalamus, and your hypothalamus. Okay, very, very important parts of the brain. Your white matter lies beneath the cortex. Okay, it's the main part of the brain that you see. And all they are is essentially they're transferring axons that are myelinated, which means they just contain a myelin sheath. The cerebrum, which is the largest aspect of the brain, is broken up into different functional lobes. So your frontal lobe is responsible for your motor, behavior, emotional, higher intelligence. Parietal takes care of a lot of sensory. Temporal lobe is all about your hearing and your olfactory capability. Occipital is primarily your visual centers. And then if we look at the thalamus and the hypothalamus, the thalamus is responsible for the integration of sensory stimuli, and the hypothalamus is the connection. It regulates many body function, especially the regulation of the endocrine system. Within the brainstem, the midbrain is responsible for fine-tuned visual auditory reflex centers, while medulla oblongata takes care of your cardiac vasomotor, so your dilatory responses, and the respiratory centers itself. And then right at the back of the brain, you'll have your cerebellum. That's a major regulator of motor activity, and it also has integration of sensory input from the spine and your vestibular organs as well. The spinal cord, as we travel down, is also made up of grey and white matter. Okay, the white matter is again just the myelinated nerve fibers, where the grey matter makes two different horns, both the anterior and the posterior. When we get down closer and we look at the peripheral nervous system, then we start to actually get a lot of our functions. So the peripheral nervous system is broken up into spinal and the autonomic nervous system. So the autonomic is all about your parasympathetic and sympathetic pathways. Okay, so we know a lot about those, whereas your spinal nerves has both a ventral root, which is the axons of the lower motor neurons, and then it has what's known as a dorsal root, which is made up of the spinal ganglions. So if you look at the area that is all about receptors, that is essentially taken care of by the dorsal root of the spinal nerves itself. When we have a closer look at the cellular structure, we know that a neuron can be an extremely long cell, and it's what's known as a non-dividing permanent, so a post-mitotic cell. It's made up of pericarins. It also has dendrites, and then of course axons, which are mostly myelinated axons especially when you finish developing. The nervous system is supported by a lot of supporting cells called villi, and those villi are capable of dividing. Okay, other supporting cell is your Schwann cells and your oligodendrocytes, which are responsible for creating myelin sheaths around the different nervous systems. So as a means of function goes, the nervous system consists of extremely highly specialized functional units. Okay, the CNS is protected from mechanical injury by the skull and the vertebrae, and the CNS separates from the body by the meninges and what's known as the blood-brain barrier. So the brain and the spinal cords are surrounded by this cushioning cerebral spinal fluid. Okay, I'm pretty sure that counts as an overview, so we'll move straight into our disorders. And we'll start with one that you probably haven't looked at before, and it's those developmental disorders. So developmental disorders can be broken up into a dysraphic disorder, and the disorders are classified as a series of disorders that process disruption in the actual development of the fetus itself. Okay, so the CNS, as you're developing from a fetus into an embryo into a child, actually develops from a plate of tissue. It's called the neural plate. And what happens is it folds. As it grows, it folds along, and those folds give rise to the brain and spinal cord, the skull and the vertebral bodies, and then the skin that's covering it. So this dysraphic disorders are anything that goes wrong with that particular process. And these ones are heavily associated with folic acid deficiency in utero. So the ones that we'll take a closer look at is if we look at anencephaly, that is a severe condition that ends up in the child's death in utero. So it's a failure for the actual back of the skull to form. Okay, therefore the brain is destroyed before the actual child comes into life. Now, meningocele is more of a mild type condition, but this happens when the meninges actually bulge out from in between the vertebrae, and then you end up with this profusion filled with cerebrospinal fluid. Okay, and that's meningocele. Now, myelinomeningocele is like meningocele, but it's far more debilitating because it has the sac that's bulging out, but then it also has the protrusion of the meninges and the spinal cord itself through this bony defect. And the one that a lot of people would have heard of before is we just look at spina bifida. So spina bifida is the absence of vertebral arches. Okay, so you're actually missing one of the vertebral arches itself, and this allows the meninges and the spinal cords to be exposed. So when types of spina bifida occur, they can either just have a covering of skin, or a clinical feature can be a covering of hair as well. Now, severe spina bifida can actually lead to paraplegia. So these particular disorders happen because whilst the fetus is developing, there essentially isn't the required nutrients in order to properly develop the body. So they'll end up with these central nervous system metamorphosis, if you will. Okay, from developmental disorders, we'll just have a quick look at different types of trauma. Now, obviously, there's lots of trauma. We talk about it all the time, but simple breakup of it is trauma of the central nervous system includes your brain injuries, so your contusions, your concussion, even lacerations of your brain. But it also can include the neck and the spinal cord, so either hyperextension or hyperflexion type injuries. When we get a closer look at the classic concussion and contusion type injuries, then obviously you need to bring into the concept of a contra-coup contusions. Obviously that's when you hit something at high impact, and it causes the brain to actually rattle in between the skull as the body slows down. But something that can happen through a myriad of different mechanisms is intracranial hemorrhage. Now, the different types of intracranial hemorrhage we can look at either within the picture in front of you. So the extradural hemorrhage is also called the epidural hematoma. Okay, so the epidural hematoma is bleeding in between the skull and the dura mater. So if you remember, the dura mater is the thick, leathery protective layer, the outer layer of the actual meninges itself. So the mechanism is usually associated with a rupture of an artery. So clinical features is, you have lucidity intervals followed by coma, and it can be very, very fatal if not recognised, and it's often caused by blunt trauma to the head. Unlike a subdural hemorrhage or subdural hematoma, that is a bleed in between the brain and the dura mater. So you're within that space. Mechanism is rupturing of venous sinus, okay, following blunt trauma, and it's often associated with a slower bleed. So the signs and symptoms come on a lot slower. Clinical features are quite non-specific. They can just be a headache. Okay, some people will get a subdural hematoma that will clot over, and then the body will just absorb the blood. Other times it can be quite debilitating, and if you have a chronic episode, especially in the elderly, you can have changes in personality, memory loss, and just that gradual confusion as well. So it's quite a chronically slow bleed. Okay, unlike your subarachnoid hemorrhage, which is bleeding within the meninges itself. So this is mechanical ruptures of arteries. Okay, so a classic one is Berry's aneurysms will actually rupture, or you can have traumatic contusion of the brain. Now, this causes irritation to the meninges. And when you get irritation to the meninges, it causes raised intracranial pressure because it disrupts the ability for the cerebral spinal fluid to actually self-regulate. Okay, and actually the cerebral spinal fluid is generated and recycled throughout the central nervous system, which we'll look at later on a little bit closer. So when you have a subarachnoid hemoclova, it can block this process and therefore cause a massive increase in intracranial pressure and is associated with a high mortality. And the last one is your actual intracerebral hemorrhaging, which is bleeding within the brain. So this is rupturing of small intrinsic arteries, often related to trauma or a stroke. Now, clinical features can be, you can get seizures, focal neurological deficits, like your signs and symptoms of stroke that we'll look at, and then it can lead on to coma, death, and a rapid increase in raised intracranial as well, depending on where the bleed is and how aggressive you'll actually find it. Okay, disorders more associated with lifestyle is your cerebral vascular diseases. Now, these diseases are the third most common cause of death in the world. Okay, so they're most common crippling diseases as well. Okay, so unlike the other ones that you get the disease, if you survive, it's not too bad. These ones here can be very crippling and debilitating for the patient. Now, the most clinical manifestation of your cerebral vascular diseases is your stroke or your cerebral vascular accidents. Now, this is often associated with a disease of old age because of the associated atherosclerosis. So risk factors are the same. If you have arterial hypertension or thromboembolisms, then you have an increased risk of getting a stroke. So a stroke itself is a local injury of the brain causing an infarction caused by disorder of perfusion, either that's atherosclerosis, thrombosis, emboli, or even hemorrhaging itself. So it is also, obviously, a stroke is a CVA or a cerebrovascular accident, and we need to remember that blood supply to the brain branches from the carotid into the vertebral arteries themselves. And it takes up about 20% of the cardiac output. Okay, so a lot of blood is going into the brain. And brain tissue is excessively sensitive to hypoxia. So you can have irreversible damage, inability to repair or regenerate after just 5 to 7 minutes of hypoxia. So two different types of strokes. You've got your ischemic and your hemorrhagic. So ischemic is your thrombotic or embolotic type 1s, and they account for 80% of all strokes. So that causes arterial occlusion from a thrombosis or an emboli itself, and obviously the risk factors are associated with thrombosis and emboli anywhere in the body. So atherosclerosis, hypertension, smoking, sedentary lifestyle, and having a high cholesterol. Hemorrhagic stroke accounts for 20%, and this is associated with more of a bursting of the arteries as opposed to a blocking. So it has intercerebral or subarachnoid hemorrhaging, and you have risk factors associated with Berry's aneurysm and hypertension itself. Yeah, the signs and symptoms of stroke, you may be fully aware of them, but they're sudden onset, and they depend on which part of the brain is affected. But generally, motor weakness, paralysis, aphasia, sensory loss, drowsiness, coma, or you can use the FAST side of the house. So, has their face dropped? Can they lift both their arms? Is their speech slurred? And do they understand you? If any of those are positive, then it's an emergency. Now, a transient ischemic attack is not a mini stroke. Okay, it's often called a mini stroke, but it's a misrepresentation of what a TIA actually is. What it should be used for is a marker of an increased risk of getting ischemic strokes in the future. So it's caused by temporary reduction in blood supply, leading to ischemia injury, but not infarction. Usually it's a result of a thrombi which lyases itself spontaneously, or it can be caused by a vasospasm. You'll have neurological symptoms, but they're not permanent or progressively getting worse. Okay, infections of the central nervous system can be caused by all of them. So you've got bacteria, viral, protozoal, and fungal that can cause it. The way they get into the body is either by a hematogenesis route, hematogenesis route from what's known as a septic emboli. So the most classic one of those is from your infected endocarditis, if you remember back to the cardiovascular system. It could also be from a localized extension, so an infection around the face itself, so dental infection, sinus, middle ear, that can also spread into the meninges and therefore spread into the brain itself. And then there's obviously penetrating trauma. So meningitis is probably the most common cause of a infection of the central nervous system, and it's defined just purely as inflammation of the meninges. So it is by far the most commonest one, and the most common of them is caused by a bacterial infection. Other ones can be tuberculosis. You can argue whether that's a bacteria as well. That's a chronic form of meningitis. Syphilis, even though it's a bacteria too, you can think of that differently. And then I'll finally get to a different one, which viral meningitis is also a possibility. Okay, but as you know, that most of them are associated with bacteria. Now, clinical features that you find is read the signs there, but the main ones is you've got a really severe headache, you will have a fever, and an associated rash. Now, this rash we'll talk about a little bit later, but you can also have photophobia and stiff neck. So people will often fail the slump test as a result of it. Meningitis can cause a series of complications like seizures, neural damage, so stroke and nerve damage themselves. You can have secondary or compensatory hydrocephalus, and it can become septic and cause septicemia. Now, a particularly nasty one to look out for that has a very characteristic rash and often goes septic is your meningococcal meningitis. So that's where you'll have that really pinprick type rash that is non-blanching. So if you were to press it, it doesn't actually change colour itself. And it's often associated with systemic type problems, and that means that it can include damage to your adrenal organs, damage to other organs. So it's definitely one to look out for, and it's a reason why a lot of us are vaccinated to 4 different strands of meningococcal itself. Okay, 2 other types of conditions that you can look at associated with the nervous system itself fall under the category of an autoimmune disease. Now, it's a little bit confusing because Multiple sclerosis is a chronically progressive demyelination disorder of the central nervous system. Okay, now it's not linked definitively to autoimmune. They think it's autoimmune, but they can't quite prove it. Okay, but so the triggers are still unknown. There is question of genetic susceptibility and question of viral infection. What they also know is, on top of that, women are twice more effective to get it than men. It's age related, so in most cases present in 20s to 30 years of age. And a really interesting epidemiological finding is there's extremely low prevalence of MS in people born close to the equator. And there's actually a linear curve in more numbers of MS the further you get away, either north or south, doesn't matter, from the actual equation, from the equator. So meaning further you live away from the equator itself, the more likelihood you have of having multiple sclerosis. Okay, it's quite rare, generally speaking, but that's what they found. So they're hypothesizing whether it's sun related, that sort of thing, but nothing's been proven. Now, when we talk about chronic demyelination, what it means, if you remember back, the myelin sheath is responsible as the insulator for your neural impulses. So as an impulse passes through, it has specialized areas in between the actual myelin sheath that allow for the leakiness of sodium to come in. When the channels are open, so voltage-gated channels are open, that increases the actual serve. So it increases the impulses and follows it along. So when it's demyelinated, that actual action potential isn't passed on. Okay, now what is even more interesting, if you ask me, I get excited about some pretty weird stuff though, but what's more interesting is when you are developing, when you're young, when you're developing, your nerves aren't actually myelinated. So what they have is they just have sodium channels all along it. And then as you develop and myelin sheaths are created by Schwann cells or oligodendrocytes, they actually move. And these actual voltage gates will move to the islets of Rugail, in between the myelin sheaths. But in the event of damage in multiple sclerosis or even Guillain-Barré's, they don't migrate back, and therefore people get symptoms. So again, they don't actually know why that these actual voltage gauges don't migrate back. Just as a little bit of a segue. But back to the point, when we look at symptoms of multiple sclerosis, you can have episodal exacerbations and remissions of neurological symptoms. So the nervous system is pretty good at finding alternate pathways, is basically what we do know about the nervous system. So you can get sensory abnormalities, so loss of senses like certain touch, vibration, heat, pressure, whatever it is. And you get motor abnormalities as well, so weakness, unsteady gait and coordination, sphincter abnormality, and unfortunately it is completely an unpredictable course because it can affect any of the myelin sheaths associated with the body. Okay, unlike Guillain-Barré's, which is an incredibly rare condition, which rare condition that affects the lower motor neurons of the peripheral nerves. Okay, and is damage through demyelination as well. Now this one has been linked to autoimmune disease, so antibodies directed at the peripheral nerves will actually cause damage. So the antibodies will attack the peripheral nerves sheaths. Now what they do know is they don't know exactly which pathogen is responsible, but they know that the cases that have been caused have developed in 2 to 4 weeks after a viral or bacterial infection. So clinical features is weakness with progressively central, can be followed by paralysis and then followed by recovery. Now, death of people that have Guillain-Barré's occurs in about 2 to 3% of all cases. Okay, our degenerative conditions are ones that we will see a lot of, and we won't focus on all of them on the screen. We'll just pick a few different ones. So the direct definition of degenerative conditions is progressive loss of neurons in functional areas of the brain. And obviously each condition will affect a different area of the brain. So starting with Alzheimer's, Alzheimer's is the most commonest cause of dementia. Now, dementia is defined as a progressive loss of your cognitive function. So you'll end up with a functional decline. This can be in memory, in perception, in intelligence, in speech ability, in understanding language, all that sort of stuff. Okay, it's all linked together within dementia. Now, it is quite sporadic, and we don't exactly know the cause. Again, we have a lot of links, like magnesium, aluminium toxicity, not using your brain enough, etc., etc. But we don't actually know exactly what it is. We do know that it affects older people more. So there's a hell of a lot of people that are over 70 that have Alzheimer's disease. So when you look at the actual brain itself, the brain appears atrophic, so it shrinks. And what you have is you have narrowing of the gyrate and widening of the sulcus. Okay? Now, mainly the atrophy of the cerebral cortex itself is followed by secondary hydrocephalus, which is like a compensatory increase of the amount of cerebrospinal fluid to make up for the loss of brain tissue. So it wants to fill the space. So obviously, it's the cerebrospinal fluid will rotate itself based a lot on pressure and maintaining a certain pressure. So when the brain atrophies and shrinks, obviously as a means of compensation, you're going to get an increase in CSF. Less brain tissue, more CSF. Okay, so it's secondary hydrocephalus. Now, Parkinson's disease is a progressive loss of the pigmented neurons. Okay, so pigmented neurons that are found in the substantia nigra. Now, substantia nigra is part of the basal ganglion. Remember, the basal ganglion is the grey matter found beneath the outer cortex and responsible for basically your fine motor. So it's really, really important in controlling motor outputs. Okay, the basal ganglion is what is responsible for us being able to do complex and fine-tuned movements. Now, again, the substantia nigra of the basal ganglion is responsible for producing the neurotransmitter dopamine. So when it's affected, we have a chronic reduction in dopamine itself. Now, it typically affects the elderly again, and you have an onset at around 45 to 60. Now, the clinical features is you have obviously a loss of motor coordination, tremors at rest, you get rigidity, slow movements of bradykinesia, postural instability. You're very, very unstable because your proprioceptions don't actually work as well, and you can also have difficulty speaking and swallowing. It has a 10% associated link with developing depression and dementia as well. Huntington's disease is very, very uncommon, but it's interesting. Okay, so it's a degenerative condition that has been linked to an autosomal dominant transmission. Okay, now to make it quite confusing, it is Huntington gene mutation, not Huntington gene mutation. Okay, I think it's very, very cruel, makes shit hard to remember, but why not, hey? Now this causes atrophy of the cortex and the subcortex nuclei itself. So the first symptoms, they don't appear until about midlife, but mostly you become mentally incapacitated by the age of 50 to 60. So when people are younger and they carry this mutation for Huntington's disease, they're actually completely fine. They can be high functioning members of society, and then by about midlife they start to progressively slow down within their mental capacity, unfortunately. And then by 50 and 60 they're very incapacitated, and it will often involve dementia, obviously, and involuntary abnormal movements, sort of like outburst of random movements as well. Now, the last one we'll look at in this one is your amyotrophic lateral sclerosis, okay, which is also known as motor neurons disease or even Lou Gehrig's disease. Okay, so ALS is what a lot of people know it as. Obviously, thanks to the Icebox Challenge, it made people aware that ALS actually exists, and that's it. Okay, but the definition of it is a neurodegenerative disease. It's characterized by motor weakness and progressive wastage of your limb muscles. Okay, because The limbs aren't actually the muscles in the limbs aren't getting stimulated, therefore they're going through atrophy and wasting. It affects mostly older men. The cause is unknown. That was the whole point of the Ice Bucket Challenge, was to raise money in order to find the causative agent of it itself. So what happens is the loss of motor neuron in the spinal cord, midbrain and cerebral cortex is linked to a loss of your lateral cerebral spinal motor pathways. And that causes incurable progressive diseases which can lead to death over the years. Okay, so a direct reduction in neural pathways and neural stimulus can lead to people's death from muscle wastage over the years. So what you'll find is weakness and wasting of small muscles in the hand. Fasciculations can also occur, slurred speech, and then your paralysis as well. And the paralysis is obviously what causes death when dealing with the muscles associated with breathing. Now, another type of degenerative condition that is not here is your dementia. Trying to think how to pronounce it. It's like a fancy name for boxers. It's a Hydrocephalus. Okay, but if you want to, you can call it punch drunk, or you can even call it chronic traumatic encephalopathy. Okay, so because even that's easier than saying it. Okay, but this is progressive disorder that affects boxers, wrestlers, athletes who get repeated concussions over and over and over again. So from the repeated concussions, you get an onset of symptoms like early dementia, tremors, and other neurological features, which can be months or even years after the concussion. Okay, just think of our friend Muhammad Ali and how he is now, and that's an example of chronic traumatic encephalopathy. Okay, the last few that we'll look at the disorders that are associated with the actual cranial space itself. So if we look at a generalized thing, so intracranial space occupying lesions are a series of conditions that will cause the cranial space to fill up. So obviously the cranium is a rigid structure with very few openings. So when the cranial space increases, it increases your intracranial pressure, which we all know what that can do, and it can also cause a displacement of brain tissue through shifting or herniation itself. So from there, you can get seizures, epilepsy, hydrocephalus, altered conscious state coma, and the effects of herniation, as we know, depending where they are, especially if it goes through the foramen magnum, can be a loss of control in respiration and a blood pressure impairment leading to death. So common causes of space occupying lesions is cerebral edema, abscesses, hematomas, and then your neoplasms as well. So your brain tumours, we're seeing as tumours, 50-50. So 50% of them are primary, meaning they start in the brain, and they're usually solitary. So just one brain tumour growing in the brain. The secondary ones usually occur in multiple lesions, and they metastasize from breasts, lungs, especially the bronchus, kidney, colon, and then your malignant melanoma. Now, both of them, primary and secondary, can be benign and malignant, and can both significantly affect your function itself. Now, hydrocephalus is an increase in volume and pressure of the cerebral spinal fluid. So if you think back to when I explained the cerebral spinal fluid, cerebral spinal fluid is made and secreted by the carotid plexus, which is right in the middle of the actual brain. You'll see it there next to the diencephalon. And then, as it travels around, it gets reabsorbed by the arachnoid villi. Okay, so the arachnoid granulation with the arachnoid villi will actually absorb it, and then it will push it into the lymphatic system, and then it will recycle around the body, and then it reproduces more. So total volume is pretty small. It's only about 140 mils, and it's quite stable. Okay, and it recirculates several times a day. And the reason it does that is it wants to remove metabolites from brain function and waste products to protect the brain further. Now, in the case of hydrocephalus, there's a obstruction in this drainage process. Now that can be caused by congenital reasons, following meningitis, your tumours, and you can also get your hematomas as well. Either way, it causes an increase in pressure because of the inability to drain and recycle this CSF. Okay, last two conditions we'll just touch on quickly is epilepsy, for starters. So definition is a neurological disease characterised by reoccurring seizures. So we're focusing on reoccurring seizures, not the one-off that's caused as a manifestation of a different condition. So it's defined, seizures are defined as abnormal electrical activity in the brain. So we can have generalised, which affects the entire cerebral cortex, typically associated with loss of consciousness, and then a focal seizure, which affects part of the cerebral cortex. So clinical features of epilepsy depends on which part of the cortex is affected. So in the case of convulsions, that spreads to the primary motor cortex, right at the front, and that's where you get your violent shaking, that sort of thing. Other symptoms you can find is just short periods of altered consciousness, like an absent seizure, abnormal movements, just in general, not necessarily violent or repetitive. You can also get an abnormal sensory phenomenon like smell, taste, even sound sometimes. And then, because it's the brain, you can even have epilepsy that's associated with inappropriate behaviours. Now, the causes of seizures is very, very different to epilepsy. So epilepsy is mostly idiopathic. You don't actually know what causes it. People just have a trigger that causes primary